in COVID-19 patients now that that treatment has been received emergency use authorization going forward. But first, let's talk about some numbers. Since Monday, our state has seen an increase in 1,328 COVID-19 cases and sadly 12 new deaths. Kansas now has a total of 43,940 cumulative cases with 458 deaths. We have an increase in 8 new clusters since Monday for a total of 178 clusters which are active. Kansas, in the weekly White House report that I've referenced before, its new cases are at 152 per 100,000 cases, which put us in the red zone, which means we're the 6th highest rate in the country. The U.S. average is 88 per 100,000 compared to ours at 152 per 100,000. Also, Kansas, in the same White House report, is reported, and it agrees with our internal numbers, 9.3% test positivity rate, which is the 11th highest in the country. In the same report, better news, Kansas is in the green zone, meaning more favorable in terms of testing per capita at an average of 1,550 per 100,000 compared to the FEMA HHS region in which we reside in the middle of the country is at 1,253. So we're outperforming some and are better than average, which is good. In terms of outbreaks, there are 14 outbreaks and 106 cases associated with sports. 6 of those are among college teams, including soccer, volleyball, and football. 6 are among high school or club teams, including volleyball, football, baseball, and basketball. And there are 2 outbreaks among sports camps, including wrestling and volleyball. There are 5 outbreaks and 38 cases associated with either elementary, junior, or senior high schools. Most schools haven't started yet. And not surprising then when I say that most of the cases that I referenced in schools are associated with the administrative personnel and school meetings that have occurred prior to the start of school. Only one of those positive cases was in a student. The others 37 are in staff or faculty. 20 outbreaks and 250 cases so far among colleges and universities. I'm sure that the number is higher than that because the data reporting lags a little bit behind and the number of cases are, I'm sure, going to increase as the number of people returning to campus occurs. 231 of those cases, by the way, are in people 18 to 23, and 26 of those are in 24-year-olds or older. One more comment. We've been working with the CDC Foundation, the foundation arm of the Center for Disease Control and Prevention, and we are going to have been granted some funds. We are going to bring on a new epidemiology staff to be working in our agency, funded by the CDC Foundation, for an industrial hygienist. An industrial hygienist is a person I think of as a combination of somebody that is an expert in infection control, safety, and engineering. And Dr. Hawkinson and I were talking just a bit ago about air handling and the impacts of that, if they're significant or not, plumbing, and the physical structures indoors. An industrial hygienist will help us to consult with high-risk facilities like skilled nursing facilities and the like. And then secondly, we have an additional CDC Foundation staff member that will be joining our state lab as an informatics specialist. As you can imagine, with the activity going on with this pandemic, the data needs and the data aggregation and analysis are increasing dramatically. So to get additional informatics help will be helpful for us. Okay, now I'm going to shift gears to convalescent plasma. And again, Dr. Dana Hawkinson, longtime colleague, I might add, we've worked together for many years. On August 23, the CDC, actually the FDA, issued an emergency use agreement for an investigational COVID-19 convalescent plasma. Let's start with the basic. What is convalescent plasma?
Well, convalescent plasma is a blood product that is circulating through your vascular system. So it consists of, in your vascular system, you obviously have red blood cells, white blood cells. In convalescent plasma, what we are looking for, the main component that we're looking for, are the antibodies. Antibodies are tiny proteins that your immune system creates, and certain cells excrete those antibodies. Those antibodies then cling on to either the virus or the fungus or the bacteria or whatever invader you may have. Obviously, in this case, it's SARS-CoV-2. When the antibodies are able to coat the virus or the foreign invader, they then block the activity of that foreign invader. Specifically for this virus, we are really looking at the antibodies blocking the ability of the virus to get into the cells via the receptor. And the receptor for SARS-CoV-2 is the ACE2 receptor. There's also a co-receptor called TMPRSS2 as well that helps with the virus to get into the cells. But the main thing that the convalescent plasma has is the antibodies, which look to neutralize. And so many people understand, or I've heard, neutralizing antibodies. And that's what convalescent plasma has in it, is those neutralizing antibodies towards SARS-CoV-2.
So you can't go down and buy it off the shelf.
No.
It comes from someplace. Where did the antibodies come from that we use in a therapeutic situation like this?
Mm-hmm. So the antibodies are created by our cells, by B cells. They are clonal, meaning that there is a single B cell essentially that is able to interact and create this antibody. As these B cells continue to expand, a specific one that is able to create the antibodies against SARS-CoV-2 is able to expand in a clonal fashion and create those antibodies. It should be noted, however, that our body sees a lot of, or our immune system sees a lot of different pieces or epitopes of these viruses, of these bacteria, of these fungus. So there isn't only one type of antibody made. You actually make quite a few or several important antibodies towards SARS-CoV-2. But we are looking at the antibody specifically that looks to neutralize the infection.
So the antibodies are taken out of the blood of somebody that has had the infection. They're stored, and then they're given to a person
Yes.
that has not yet made their own antibodies. And so they're getting them from somebody else to attack the virus, which is in their body.
Correct, in hopes of prior to your antibody stores being built up. And again, we should note that for specific types of antibodies, the two types of antibodies that we're looking for in this infection and most infections are called IgM and IgG. Those are just designations of the different kind of antibody types. An IgM antibody type is more of a short-term acute antibody, whereas the IgG is the long-term antibody. And that is what most of us produce when we see infections so that we can have long-term immunity. And that's the IgG antibody. So we are really hoping to get a lot of these neutralizing IgG antibodies from the blood product, from the plasma of these people, of these patients that have been previously infected with SARS-CoV-2 and have recovered.
Now, at KU, I believe, participated in a Mayo Clinic study, and that was, I think, at the National Institute of Health, I believe. Can you tell us a little bit about how that study went? Have you seen patients and taken care of patients who were given the convalescent plasma?
Yeah, absolutely. So we were a study site for the Mayo trial for convalescent plasma. It was run by Dr. Wissam Elatruni with our Division of Infectious Diseases. Him and a couple colleagues were able to consent patients, meaning they went through with them all the benefits and risks of getting convalescent plasma. They were able to consent at least 70 unique patients, so we were able to give plasma to at least 70 unique patients. Overall, I don't know the full extent of outcomes and deaths from our study in particular. We have some interim or some early published preprint data from the Mayo study in general. But yeah, we were actively giving it to our patients at the University of Kansas Health System.
Is it too soon to know if it's been effective?
So there is a preprint, and I believe they looked at 35,000 patients that were given convalescent plasma under this program. Again, the University of Kansas Health System was one of the members of that program. There was also a study looking at 20,000 patients through the program as well, and that study looked at safety. So it was very safe with significant adverse events in only 1% or less of people that received convalescent plasma. As far as efficacy, it's very difficult to learn because there are several different factors when we talk about efficacy, specifically for COVID-19. So with people with SARS-CoV-2 infection, the things that we want to look at are the time to symptom onset or time of infection. That seems to be important. So are you getting the plasma 1 to 2, 3 days after your symptoms start, or are you getting it 7 days or a week later? That seems to have an impact. How critically ill are you? That seems to have an impact as well. In addition, I talked about the IgG antibodies before. We have to know the concentration of the IgG antibody within the plasma, because it seems that the concentration may have an effect as well. Again, there was no statistically significant findings from this, but there were signals from this large study that if you had more mild illness, if you got plasma 3 days or less from your symptom onset or hospitalization onset, that you would do better. In addition, if the convalescent plasma had a certain amount or a certain antibody titer in it, that could also give a signal that you may have more benefit than if it didn't.
Question, so let's say he had COVID-19 and survived and has an antibody test that's done, and she has COVID-19 and needs to, or would benefit quite possibly from that. Do they have to be of the same blood type?
Not that I'm aware of, no.
Okay. And then do you have to quantify the amount of antibody in the blood of the person who has gotten over the infection, or has anybody that's been infected and has COVID-19 antibodies be considered a donor for that?
Yeah, that's a great question. So we do believe, and again, there was some signal, but not really statistical significance of this large study, that the amount or the concentration of antibody did have an effect and did matter. In general, what we have seen is that people who have mild disease or who are not very ill have lower amounts of antibody compared to someone who may have moderate or critical illness or severe illness. And so, but to fully understand how much antibody you have to have a special test so that they can titrate out, so that they can measure the amount of antibody.
To quantify it. Just 1 minute, Martin, and we'll get at it. I get a report, and I've commented before at one of these press briefings, that I get a report from the American Red Cross, which, as you know, is a blood center, big blood program all over the country, the world. And it's interesting because they give the report every state who has, of the donors, what percentage of the donors are positive for IgG or IgM. Yeah. And it's a very small percentage. It's about, it started off at below 1 and now is up to maybe 2% of the population. So it's not like with all these numbers of cases I'm talking about that there's not a lot of prospective donors out there. Is it your opinion that the supply of the antibody won't keep up with the demand, or is it just too soon to know? You know,
I think right now we are really good on the supply of convalescent plasma. There has been a lot of people in Kansas, in the Kansas City community where I live, but in the nation, of people that have recovered that want to help other people. So I think there are active donors who want to get out there and donate. I'm contacted on a weekly basis about people who want to donate. So I think that so far the convalescent plasma supply is pretty good. But again, with everything else in SARS-CoV-2, in the pandemic, we have to really understand the dynamics within your community.
Yeah, okay. Any last comments, Dana, that you'd like to share with the gang on particularly on convalescent plasma, its potential for use, where we are now, or anything for that matter?
I think initially on your last point about the seroprevalence, when people are testing donors and they're looking for antibodies and they don't have a large amount, we can do studies called seroprevalence studies to really look at how much has the infection been out in the community. And when it is a small number, it's kind of concerning in one way, but it's good in another. It's concerning in the fact that people are talking about wanting to get to herd immunity. And for that, you need probably 90% or more in the historical sense of herd immunity to have been infected. When at this point in time, there is such a small percentage of the population that's been infected, to get to that 90%, that can mean that there still has to be a lot of infections that need to occur. And we know that with a lot of infections, even with the small proportion of people that have to go to the hospital and have critical illness, that can be a very high number. In addition, we should note that convalescent plasma is not a magic bullet. We do have a treatment regimen for COVID, but none of it is a single magic bullet. We understand we have remdesivir, which is an antiviral. We also have anticoagulation to help prevent against the blood clotting, and we have steroids. The fourth tool in our armamentum is convalescent plasma. Unfortunately, we've had now these trials stopped, and we have this emergency use authorization. So it is going to make it a little bit more difficult to further study the effects of convalescent plasma to see what beneficial effects, if any, it has when given to COVID-19 patients. And again, I think a lot of it will center on how early after infection or symptoms are you going to give convalescent plasma? How sick is that person? And in what quantity or what concentration are the antibodies to SARS-CoV-2 within that convalescent plasma as well? We will still try to get those answers as a medical and scientific profession, but it's just going to make it a little bit more difficult now with the EUA.
Yeah, and I might point out that when people donate the plasma, they go in and it's rather like a blood donation, except they skim off, if you will, the antibodies and give you back your red cells.
Yes.
So it's not purely like a blood donation where you give whole blood. It's this plasmapheresis process where they skim it off. Okay, thank you very much. I know there's going to be some questions in just 1 minute. I want to end with a cautionary note that must be said. The ABATE, A-B-A-T-E, the ABATE rally in Jefferson County is starting tomorrow. It's an example of where we're letting our guard down, quite honestly. I talked earlier about these numbers that are going up and up more. And why are those numbers going up? And the reason is we're not paying enough attention to the things that we know are effective. And this rally that I just commented on, greater than 5,000 people at Lake Perry in Jefferson County, begin tomorrow. I believe we can anticipate that, although it's much smaller than the Sturgis, South Dakota event, the Sturgis one has spawned hundreds of cases in 14 states already. I'm sure we'll see an outbreak related to this Lake Perry event. What I would do is put out a plea that if you do go to that one, motorcycles, wear helmets, and take the precautions against getting infected. Those are the end of prepared comments. Free to answer some questions. Marty.
One donor benefit or help?
Say it, ask it again.
How many, if
Oh,
someone
okay.
gives the coronavirus, like how many people do they help?
Yeah, I'm not really sure on that. I know for a unit of plasma, it's 200 milliliters. We typically give 2 units of plasma per patient. You can get 1. I'm not exactly sure how much they draw off per donor. It's at least 1, if not 2, but I don't have the final number on that.
That's good. We'll bring that answer back next time, Marty.
The decision to identify the locations of outbreaks, will that be retroactive?
No, it'll start the day that it starts, on a week from today. The question was, we are going to start identifying on our KDHE website by name where there are outbreaks, whether it's schools, universities, private businesses, once they reach a certain threshold for active outbreaks. And it will not be retroactive. It'll start the day with the active ones that are on the 9th, and we'll update it weekly.
It's up to the local governments, I mean, local health officials, what changed that there's been this about face?
Yeah, we've always deferred to the local government. The question was, why have we changed? Because in the past, we generally speaking did not release the names of organizations, businesses, schools, churches, et cetera. And the reason was because for the most part, that's what the local governments preferred, or a substantial number did. The reason we've decided, and first off, a lot of the local entities want to start doing this also because they're struggling to keep ahead of the number of cases. And I know in talking this with the governor, and I know you've seen her press release from earlier today, is felt with the numbers all going the wrong direction. We're, as I mentioned, the 6th in the nation in terms of the number of new cases per 100,000. We have to start getting more serious. And one of the ways to do that is to provide to provide people the information they need. Because there's a lot of people that are asking us too, how do I know if my loved one in a nursing home, for example, is infected? From a consumer protection perspective, they want to know because some of these entities have not been forthcoming. How do I know if there's an outbreak if my school doesn't choose to divulge that information? Or is there someplace I should be avoiding? How can I know that? And it's not meant to cause a great deal of heartache in businesses, schools, churches, organizations. It's meant to provide information so people can make informed choices as to how to keep themselves safe.
How did you choose the numbers for that? Those seem to be different numbers. The
It's
press
some-
release said something about different numbers than have previously been reported or.
Yeah, we picked a number of 5. That's, an outbreak or a cluster is defined as 2 that are epidemiologically linked to one entity. We've chosen 5 because for the most part, you're getting cases that are getting better, and then new ones are cropping up. And it's, to be honest with you, Marty, it was just a balancing act. We don't want to, and it was a natural dividing line when we looked at the number of active cases, that it wouldn't include 90. If we had included 2, it would include 100% of the cases out there. If we had 5, it would drop it down to about 50, 60% of the cases. It just made more sense with a natural break. We did 20. One of the things we're sensitive to is that we're pro-business. We want to help businesses thrive and to be safe places for people to do commerce. And that's why we've set that for a private business at 20. Again, there was a natural break that occurred there. And again, to assist businesses to be a safe place for people to do commerce. And those are the numbers we picked. There's natural break points on both of those.
Is there a difference between cluster and outbreak?
No, not really.
Okay.
Yeah, the cluster is a definition from the CDC. People colloquially will use the word outbreak, and we use them essentially interchangeably.
With high school sports starting on Friday, so many kids who have been diagnosed with COVID-19 now, are there protocols that students or high schools should take to avoid rushing back out on the field?
Yeah, that's a very good question. As Dr. Norman stated, sports are very important, but they aren't essential. So we know that they are important for many things, as is school. Nobody will deny that school is important for kids to be at in person, but is it going to be safe? Is it going to be safe for those children? For the most part, children don't suffer or don't have the risk of suffering the disease that adults do. But what about those children who are interacting with the adults in the school system? What about the children who are interacting with the adults in their household? Are they part of vulnerable populations? We know a lot of people based on surveys and reported in journals, that a lot of people who do work in those schools do have risk factors for disease. We know that a lot of people that those children go home to have risk factors for disease. Are those children going to be at risk when playing sports? We simply don't know the answer to that question. Are they going to be at risk of spreading the disease between themselves and their coaches? Certainly, I think everybody needs to understand those risks and do what they can and take those little steps, each one individually, those steps individually, but also as a collective, as a team or a athletic department, to try and mitigate those risks. Because so far what we have seen by different high schools and other schools going back, whether that's in other states that we've seen reports of, or even colleges, when we have especially these younger people getting together, the disease spreads easily among them.
I'm thinking specifically of students who have had the disease and have recovered. Are there concerns with enlarged hearts or that sort of thing if they rush back into?
Yeah, so for the myocarditis issue, certainly we know that people who have had the disease and have no symptoms at all have changes on their CT scan. In their lungs, we know that people who have had the disease and have had symptoms, when they look at their heart through an MRI, they've had changes to the MRI. We don't fully know the answer to that question. And that is kind of what we will be looking at moving forward as far as younger athletes, high school athletes, college athletes. I don't think we know the answer to that question right now. And that is certainly one of the many, many questions that will hopefully be answered in the next 3, 6, 9 months to a year. We can get more concrete answers on what is the risk to our young people, our young children, our young college and high school athletes after having COVID. What is their risk of adverse events? say with their heart, with their lung, anything like that. But right now, we don't have any concrete answers for that.
One more question.
With the flu season coming, doctor, is there any way to put people at ease? Oh, I have the flu, I don't have COVID. I mean, you talk about certain symptoms and everything. Is there any definite way not to freak out like, oh, I had the flu last year, you know? Just, is there any way to put
Well-
the community at ease on something like that?
Yeah, so we're coming into the flu, influenza, and COVID-19, where COVID-19 is obviously here. Well, first off, there's a terrific overlap in the symptoms, and it would be awfully hard to look at, talk to, and examine a patient who's ill and say, without further testing, yeah, this is influenza, or this is clearly COVID-19, or something else. The good news is that we can do an influenza A, influenza B, and now there's even a third, the COVID-19 test is being on the same multiplex test at the same time. Matter of fact, those are available now and are being used, although the same old saga, it's in terrifically short supply. So I think, and it'll be interesting to see how, I think there'll be a very common scenario, I'll be curious what Dr. Hawkinson says, I think it'd be very common where somebody comes in sick, they're negative for influenza A, influenza B, and then we may or may not have immediately access to the COVID-19 result. I don't know what the turnaround time is going to be with that multiplex test, but there's still going to be a little concern about that. And the worst case scenario, obviously, is if we have a lot of influenza and a lot of COVID-19. And I don't have a crystal ball. Do you? How's your crystal ball working?
Yeah, so it's interesting. We always take our cues from the southern hemisphere as far as influenza goes, because we are ending ours. They will be going into the winter and the summer. In the southern hemisphere, they will be going into their influenza season. As we come out of our summer and into our winter, we take a lot of cues. In fact, the influenza vaccine, what strains they look at to use for the influenza vaccine, they are looking at what is circulating in the southern hemisphere. And it's interesting, there was a recent Science article about what is happening with influenza in the southern hemisphere. And in a couple of those countries, they have noticed a significant decrease in their influenza rates. Some countries, even through mid-August, have only noted cases within the double digits. That's within the 30s, the 50s. So we hope that with all these measures that are taking place, with the distancing, with the masking, with the hand hygiene, that will cut down immensely on our influenza rates. But to your point, Dr. Norman, we are at the health system looking at the best way and the best algorithm to use for testing, because certainly a lot of these symptoms do overlap. So currently, our lab directors, Dr. Plapp and Dr. Leisman, are working on our algorithms and exactly what tests are we going to use. But just as you said, there will be a multiplex PCR, a molecular test to help diagnose all three of those, and also one that also includes RSV. So actually 4 viruses that we're going to be able to pick up, and the turnaround times are going to be different depending on what platform we're using.
Okay, thank you very much.
Thank you.